Let's talk about a task that sounds incredibly simple on paper, taking a patient's insurance card at the front desk. You take the card, copy it, and you're done, right? The reality is much messier. Patients bring expired cards, or they text in a blurry photo of the wrong side of the card. And with Medicaid coverage churning monthly and commercial plans resetting deductibles, a card that was good last month might be useless today. Figuring out the right information takes serious time. Navigating payer portals, waiting on hold, and resolving these discrepancies averages between 12 and 45 minutes per patient. Now, hand that 45-minute problem to a front desk worker who is also answering phones, scheduling appointments, and checking in a crowded waiting room. The margin for error is huge, and mistakes slip through constantly. Treating insurance intake like a simple front door greeting, instead of the rigorous data verification process it actually is, virtually guarantees that those errors will snowball into massive workflow bottlenecks later on. When inaccurate or incomplete insurance data makes it past the front desk, there is really only one outcome: a denied claim. Chart data shows denials climbing. Today, 41% of providers see over 10% of claims denied. Isolating this, 14 to 18% of Medicare and Medicaid denials stem from front-end eligibility errors. With rework, these errors cost $285 per denied claim. Relying on rushed in-house staff for this step creates a significant, high-cost leak in the revenue cycle, one that is almost entirely preventable. Most practices know they have a verification backlog, and the standard reaction is usually to try and throw more people at it by hiring another internal administrative staff member. To do that, you're looking at a serious financial commitment. When you factor in salary, benefits, payroll taxes, overhead, and training, a fully loaded in-house insurance coordinator costs about $60,800 a year. But the financial input isn't the critical flaw. Front office roles have incredibly high turnover rates, averaging under 12 months. This means your practice is stuck in a permanent, costly cycle of hiring and retraining. Every time an employee resigns, all of their institutional knowledge, like how to navigate specific payer portals or handle tricky secondary coverages, walks right out the door with them. Practice managers often keep staff in-house because it feels like they have more control, but in reality, they're just accepting chronic instability, coverage gaps, and a baseline initial denial rate that sits near 11.8%. There is a structural alternative to this cycle. Instead of relying on the physical front desk, practices are shifting the verification workload entirely to specialized virtual medical assistants. In the modern remote model, insurance data is processed days before the patient's visit. To manage this, remote teams use AI document intelligence. The system automatically reads card images and flags historical payer inconsistencies before bad data reaches your electronic health record. By the time the process is done, the verified coverage details, the primary versus secondary status, and any cleared discrepancies are documented directly inside the practice's EHR. Compare that targeted, dedicated focus to the divided attention of an in-house worker who is trying to verify an expiring Medicaid plan while simultaneously processing a copay and answering a ringing phone. Moving verification upstream to dedicated remote specialists removes the chaos of multitasking. It replaces a reactive scramble with a proactive intake queue designed to flag discrepancies early. Beyond the operational relief, the mathematical argument for outsourcing this specific task is very clear. This chart breaks down direct costs. On the left, the $60,800 fully loaded in-house coordinator. On the right, a dedicated Staffingly virtual medical assistant requires an annual investment of just $21,600. That represents a 64% reduction in overhead costs. If you scale that calculation for a mid-size practice, replacing 2 or 3 roles, you are looking at returning anywhere from $78,000 to $117,000 directly to your bottom line. Transitioning to a dedicated remote infrastructure protects thinning clinical margins by locking in a predictable, lower overhead cost for every patient seen. Of course, the primary hesitation any practice manager faces when considering outsourcing is security. Granting remote access to sensitive health records is a serious decision. The right remote partners operate under a stringent compliance framework to mitigate that risk. This includes holding mandatory SOC 2 Type 2, ISO 27001, and HITRUST certifications, with all data handling occurring under signed business associate agreements. There is also strict operational oversight. Every remote assistant is actively managed by a team leader and a quality process manager to ensure they are meeting your service level agreements. And the deployment is surprisingly fast. Practices are fully connected and live within their EHR in just 48 to 72 hours. When you step back, relying on uncertified, constantly churning in-house staff often creates far more HIPAA compliance exposure than partnering with a specialized, thoroughly audited remote infrastructure. So who needs to make this change? If you run a mid-size group suffering from high front desk turnover and your claim denial rates are creeping above 10%, you are the exact profile for this model. Who should avoid it? Ultra-low volume concierge practices. If your business model relies entirely on dedicated front door relationship building rather than high volume claims efficiency, keep this role in-house. If you do fit the profile, evaluating the service is practically risk-free. A 30-day free trial allows you to test the workflow without any long-term contractual commitment, and you can be live in 48 hours. The core trade-off here is simple. You give up the illusion of in-house control in exchange for scalable, AI-driven precision. At the end of the day, chasing down insurance cards is not where your medical practice adds clinical value. It is exactly where delegation secures reliable downstream revenue.